Hi everyone, and welcome to this webinar on the use of shockwave therapy in pelvic health. So I'm Katie and I'm the Training and Education Manager at f-ESWT. So some background about f-ESWT for those who don't know. We are a medical technology distributor based in the UK with a core for rehabilitation technologies including diagnostic ultrasound, focus shockwave and lymph touch. So we are very delighted to be joined this evening by two highly experienced physical therapists and users of shockwave therapy from the well-known John Hopkins Hospital based in the United States. So Mr. Ken Johnson and Mary Austin, thank you so much for joining us. Following their presentations this evening, we will do a Q&A session, including some pre-submitted questions that you have sent us beforehand as well. So if you'd like to ask a question at any point through the presentations, please just use the Q&A function at the bottom of the screen. So on that note, we'll hand over to Ken, who is going to be presenting first.
Katie, thank you very much for the very kind introduction. I'm very pleased to be here, presenting with, I'm not sure where get my slides under control here. I'm very pleased to be presenting with my colleague and friend, Mary Austin, who is one of the most outstanding pelvic health therapists that I've had the chance to work with. She leads our pelvic health physical therapy residency, as well as the operations of our flagship clinic here at Green Spring Station. So very grateful for the invitation to share with you what we're doing. So for our topic of discussion, I'll share a little bit of background on the focused shockwave therapy that we are using here, and then I'll turn things over to Mary, where she will share her knowledge and experience and clinical expertise in the use of the technology with the pelvic health population. A quick note about our services. The outpatient rehab services at Johns Hopkins Hospital are spread out over a fairly wide territory here in Baltimore, Maryland. We encounter a lot of different patient populations. We're actually opening our first freestanding or integrated pelvic health clinic that will open in the end of this month, actually a couple weeks. And that's been a project that's been working for a while now. The rest of our facilities are set up much like our Musculoskeletal Institute, where we have a high focus on integration of technology into practice and managing patient populations ranging from orthopedic, neurologic, cancer, and also more recently our COVID rehabilitation population. So we're talking about a modality here, and one thing that we hear a lot of times, and I find in conversations in chat rooms, I'm sure many of you do as well, that there's a high degree of focus on evidence-based therapies, and oftentimes modalities fall into this category that is often maligned, that if therapists aren't just simply manual, that they aren't, in a sense, practicing good therapy. And this is a great article, very timely for this discussion, that was put out by a good friend of ours, Phil Page, at Franciscan University, where he looked at actually adherence to the clinical practice guidelines. And right now, in a recent survey, over half of physical therapists do not follow recommendations that are given for evidence-based practice in 8 out of 11 different situations that involve modalities. You'll notice that absent on here is that of shockwave, and part of that is, shockwave and myoacoustic or myofascial acoustic compression therapy, as we call it here, is relatively new and novel in our applications, whereas internationally, I know in the UK, the topic of shockwave has been around for some time. The irony here is that the evidence that does show the significant efficacy of shockwave in its treatment of plantar fasciitis, as we know, over 80% effective, is not reimbursed by most insurance companies. So, we can talk about practice all day long, but there still are some reimbursement issues here that override things. For us, we've worked around that in how we describe the medical necessity of the treatments that we're doing and how we apply them to the therapeutic billing codes that we use in the States. But when we look at modalities as a whole, but also, those of Shockwave, the 6 dimensions that we tend to focus on are the effects of thermal, neurophysiological, pain, masking or gating effects, how we can break up, the adhesions or cross-links, affecting and improving cellular metabolism, mechanotransduction, and a goal of improving fluid dynamics. That's represented here on this simple biophysical model that we apply, or that we look at with our patients, and how we manage their chronic pain. When we look at that which is very inflamed and painful, we have modalities such as TECAR therapy, and you'll see where the mechanotherapy, the IASTM and Shockwave, kind of fits in to that early part of the treatment paradigm, where we're really trying to use a mechanical stress in order to create a physical or chemical and proliferative response. And then other things such as decongestive therapy, negative pressure therapy, such as with lymphatouch and soft tissue mobilization. Those are also very valuable and all fit within our definitions and applications of manual therapy. As we're moving into the proliferative phase, we like to use laser as both a proliferative agent, but also as a thermal, as well as photobiostimulation to try to drive more energy into that healing. But then our overarching and driving goal with a lot of this is not just to take people's pain away, but to help them improve their movement and overall improve their function. So whether it's returning to running or personal fitness with Pilates and other activities, our goal is to help our patients be pain-free and high functioning for the long haul. So let's talk real quick about a shockwave, because they're not all created equal. A true shockwave has a very high rate of rise in its impulse, and that abrupt increase or change in pressure is critical, much in the same way as using a high volt type of stimulation. We can yield a significant amount of energy in a very short pulse duration. With the shockwave, we're going to use frequencies. The pulse frequency itself is only in the 6 to 8 hertz range, whereas the duration, or that rate of rise, is only in a matter of nanoseconds. When we compare that to a radial shockwave, the radial shockwave is also using a pressure wave that's generated ballistically. So that is where either it can be electromagnetic. There's a number of different types of shockwave generators, but that's imparting a mechanical force at the surface, epidermis, and we're hoping that that force will then transmit deeper into the tissue. The dosage applies, and the amount of treatment time applies largely to how deep we are trying to actually treat. When we look at the focused shockwave, it's got several different types of generators. There's an electrohydraulic, where there's sort of a spark or a pulse that causes a rapid rise and rate of pressure waves that reflect and focus into a specific point. There's also electromagnetic generators that focus. Those can be very, very expensive and are considered to be very high energy shockwave. What we're talking about is more of a piezoelectric, and about 1/10 of the cost of the other types of devices that have been proven to be very highly effective for soft tissue mobilization. You know, all of these are using some form of a reflective or convergent point for that energy, and where that occurs is where we get the maximum treatment benefit. The other thing that is good about this is that because it is focused allows us to define the depth and much more precisely control where the convergence of that energy occurs. So if we consider the two types of generators, you know, the focused shockwave, which is what we are referring to today. We have 9 of these systems currently in our clinics, and you know, there we have on the left the shockwave generator, where that is coming from a flux in energy of the piezoelectric crystal. Using a gel, the gel is focusing that shockwave to a very specific depth and a point, obviously, that we target for treatment. What's nice about this is that it can work around structures or things that might be in the way, as either the wave will reflect off or around it, and therefore, again, makes it much more tolerated because the energy is focused at a depth instead of at the surface of the skin. You know, that's the difference we see with the radial shock waves, is that that's taking and imparting, you know, the force right at the surface of the skin and hoping that we can penetrate to a specific depth. You know, when we look at the depth of penetration, you know, most of the radial shockwave generators are able to affect a treatment depth of roughly 2 centimeters. In the case of focused shockwave, we have a variable depth based upon the type of the gel interface that we put on with the patient, so that the energy flux density maximum is varied not so much by the intensity or the amount of I call it the volume, but it is focused based off of the gel that we select, and that will go up to 6 centimeters in depth. The other thing that's unique about the systems that we're using is that it has a linear shockwave generator, and this is unique to the elevation shockwave, and that is wonderful for using along large, long linear surfaces or along fascial lines. So it allows us to take and treat that area much more efficiently from a time-wise standpoint, but is again unique to the shockwave. So at this time, I will turn things over to Mary and let her take it from here.
Thanks, Ken. So thank you everyone for joining us, and thank you, Katie, for inviting us. So I wanted to speak today on how I use PiezoWave with pelvic health diagnoses. I've been treating only pelvic health for 12 years, and 4 of those have been here at Johns Hopkins. And so prior to coming to Johns Hopkins, I did not have access to any shockwave therapy, and certainly not the PiezoWave. And so, you know, Ken has done a wonderful job in our department, really promoting this technology and other technologies to see, you know, we know the manual skills, we know thorax, we know neuromuscular education helps, but maybe what can we do to give it a little boost? And hopefully you'll see kind of throughout these 2 cases I'm going to present, even since I've been using it for the past 4 years, the research has even come a long way really in the last like 2 or 3 years. There's been more research published showing how it can really help augment pelvic pain diagnoses in particular. So I'm not sure of the audience how much of you all treat pelvic health or not. here, at least at Johns Hopkins and in our clinic, we treat all genders, any age, anybody who has a pelvis. And so, you know, the more common diagnoses that people are familiar with are more of that incontinence, both bowel and bladder, pelvic organ prolapse among women, a lot of pregnancy and postpartum related conditions. But I highlighted in here in that yellowish orange color, the diagnoses that I have found the PiezoWave to really be a nice adjunct and kind of help expedite that healing process. So particularly with pelvic pain diagnoses, when we know it's from a musculoskeletal source, pudendal neuralgia, which I'm sure a lot of you are familiar with and is pretty a tricky thing to treat for a lot of our patients. Definitely SI joint dysfunction, coccydynia, I have found it really effective in particular. And then erectile dysfunction, which is, you know, we'll get to when we get there, but my second case is on that. And it in the US, technically, shockwave therapy is not like a covered treatment by our insurance carriers. So it is, but I know in Europe, the European Urology Association does recommend it as a first-line treatment. And I don't know how that falls under your scope of practice, but that's an aside. So what I'm going to do is go through some cases and hopefully this will make sense. So I just clicked my arrow. There's a little bit of a delay, I think. Let's see.
Yeah, that's what got me too.
There we go. Okay. So just as a quick 101 for you all who maybe aren't as familiar with treating pelvic health diagnoses, the pelvic floor muscles are really a combination of like 5 or 6 muscles fused together to make this bowl that sits at the base of the pelvis. Their main jobs are postural support and work in very close conjunction with our hips as well for hip stability. Obviously urine control, bowel control, and sexual function. And they are like any other muscle in our body. So they can get short and tight, they can develop trigger points, and they can be a very significant source of pain that is often hard to treat. So just a little bit further, that'll give some background on kind of where we would apply the PiezoWave. So we have 2 layers of our pelvic floor. We've got a superficial layer on that bottom picture on the screen there. The superficial layer is predominantly responsible for sexual function and also can be a pretty significant source of pain. We obviously directly sit on these tissues regularly. You know, we don't stand all the time or lay down. And so there's a lot of direct compression and pressure on these structures. So it's hard for them to really ever get a break. And then you have the deeper layer here on the top picture. And that deeper layer, the more anterior muscles are really for that bowel and bladder control. But when you look more posteriorly, you've got the coccygeus muscle, which appropriately attaches to our coccyx. And then just superior to that, you've got your piriformis. So your piriformis we know is deep, but you can also, I think people forget it's like right next door to the pelvic floor. And obviously can be a source of pain, as we all know. The other thing I just wanted to touch on briefly are the nerves of the pelvis. So on the left here, we've got our pudendal nerve. All of the white little branching demonstrates the 3 branches of the pudendal nerve. It sits right medially to the ischial tuberosity. So just like with your ulnar nerve, how you can kind of cord over it superficially on your elbow and it'll kind of cause that zinger. You can do the same thing with the pudendal nerve. So you can palpate it externally. So for those of you who don't do internal exams, have no desire to ever, you can still palpate a lot of this externally and get a lot of good information. The other thing important to note about this pudendal nerve is it has a really thick fascial sheath called Alcock's canal, in which that neurovascular bundle travels, and that neurovascular sheath can get restricted, right? It can develop like a tendonitis with chronic inflammation and chronic pain. And so that's where the PiezoWave can actually come in really handy from that mechanical factor and kind of break up that tissue tension to give the nerve a little bit more room to move. And then just kind of showing you the posterior aspect of the hip. Again, as a reminder, everyone's familiar with your sciatic nerve, but then coming off of that immediately, you've got the pudendal nerve again, and you've got the inferior gluteal nerve and the posterior femoral cutaneous nerve, all of which can be really big pain generators in a lot of patients. So this first patient that I wanted to touch on was a 47-year-old male. And when he came to our clinic, he had been in pain for a little over 2 years. He had really severe, deep right-sided buttock pain. It radiated into the perineum and the posterior thigh, occasionally into his anterior groin and to the tip of his penis. So really anything aggravated him. Any prolonged sitting, any sexual activity, bowel movements, and impact exercise. So anytime there was direct pressure or any movement was placed, he was pretty darn uncomfortable. By the time he came to our clinic, he had already had 4 courses of physical therapy at different clinics. And the pelvic floor world here is pretty small. So I knew, like, he had told me who he had seen, and of course I knew one of them, so I kind of touched base with her to see, like, what had you done so we don't reinvent the wheel. Really, a lot of what he had done was some manual therapy, biofeedback training to really downtrain the pelvic floor muscles, and a good amount of dry needling. Of the things he had done, he did find the dry needling to be kind of the most effective, but he never really got long-term relief. So he might get relief for a day or two, but nothing's lingered. He's also seen any and every kind of specialist he can. He's seen orthopedic, physiatry, neurology, urology. He was convinced that, so this occurred when he was doing some Roman lifts and chest presses during a workout session. And he was convinced that he was kind of one of those patients who, like, he's an engineer, doesn't have an anatomy background, but like self-diagnosed himself as having a micro tear in his obturator internis. And that's what made sense to him. They ended up, finally, one of his physicians did do an MRI. He had no muscular trauma, or no, at least tear to the structure, but he had that kind of implanted in his head. He had had a few nerve blocks to those regions. None of them provided relief. He did get some injections to the obturator internis. Again, minimal relief. So he was just kind of one of those patients who's a little desperate and wanted some relief. So the most prominent findings on my exam was really his hypersensitivity and kind of neural tension. So even just doing sensation screening in the gluteals and kind of in the sacral dermatomes, I would just apply a little pressure and he would be hyperreflexive, which really just told me that his nerves were a big source of this. He also, if you just looked at his glutes, like his right glute was kind of permanently clenched and just couldn't really let go. So as I said, he had had pretty extensive therapy. I wasn't going to do exactly what he had done before, right? This is his 5th course of care. So I utilized something we have that other people don't, which is the piezo wave. And so, sorry, my slides are not advancing. There we go. So I did still do, right, some manual therapy. I did some nerve mobilizations. There's a pretty good amount of research to show that stimulating the sacral nerve roots at a low frequency with a TENS unit can also really help with that central sensitization and like sensitivity of the nerves, which I did as well. And then I added in the piezo wave, right? I wanted to see if that would just augment and accelerate the results that we had. So for him, he had that right deep gluteal pain. It really radiated into the perineum, into the tip of the penis. From my exam, I really found that it was the sciatic and pudendal nerve as the source. And my hypothesis was that both the muscles, the piriformis, coccygeus, but also that nerve sheath, the Alcock's canal I referenced, was restricting his nerves and really compressing. So I think the best way to think about this is people know what a sciatica is, and it's the same thing, but for your pudendal nerve and the gluteal region. So I would apply the piezo wave really along the medial aspect here of the ischial tuberosity, along the levator ani, which you would just apply the transducer just kind of right next to the anal opening, and then along the coccygeus. I saw him once a week for 8 weeks, and he responded really well. You know, he wasn't 100% by any means, but he was able to start to consider like, okay, I'm going to do like a walk jog program for 2 miles, right? And it didn't set him off. It didn't flare him up. He was able to sit for an hour now instead of 30 minutes. We could sit through a meeting without having to stand up and pace around the room. And he was able to resume sexual activity. So that was a big thing for this patient. He was newly engaged and he really was avoiding it. He still had some pain after sexual activity, but it was 25% of the level that it had been at. I was also still encouraging him kind of in conjunction with what we were doing to consider there are Botox interventions, there are suppositories that can be used for kind of more direct muscle release internally. And so that was kind of the next piece he was going to consider. So as I mentioned, in terms of the research for this, really in the last 4 or 5 years, there's been a lot more focus on this. So there's one study in particular, the systematic review does a really nice job showing that for definitely in the short term at 4 weeks and at 12 weeks, just weekly sessions for 4 weeks of 4 sessions of the shockwave therapy can significantly reduce pelvic pain. A lot of men are diagnosed with prostatitis incorrectly. They don't know what it is. A lot of urologists don't know what it is. So they say, here, take some antibiotics, have some Cipro, have some Acrobid, and maybe we do a repeat course of that if it's not getting better. But when it is truly musculoskeletal in nature, these patients respond really nicely to the shockwave therapy, and it's a non-invasive therapy, which is nice. The other research that I think is really helpful, and even though this particular patient wasn't a true coccydynia or tailbone patient, there are a few nice studies looking at it for coccydynia. So a lot of times with coccydynia, what happens is a tailbone just gets like hyperflexed and it's almost like a stuck drawer because those pelvic floor muscles that attach to it are short and tight, kind of pulling it forward. And so when you apply the shockwave therapy kind of right next to that tailbone along the coccygeus muscle, that mechanical compression really helps reduce the tension in those muscles and almost lets that coccyx come back to its normal resting position. And this study here that I posted there is a nice RCT where they combine shockwave to ultrasound, and they showed a much better effect with the piezo wave. So our next case, oh, hang on. Let's see if it's going to let me go. No. There we go. Okay. So case number 2, we're going to talk about how it helped with erectile dysfunction. So this patient is actually a very good story. So he was a 68-year-old male. He had recently had a total hip replacement, and he was being treated in physical therapy for his hip at another hospital in this area, in the Baltimore region. And this particular hospital had a piezo wave, like loaner device. They had one on for like a month, right? For a trial to see if they were going to buy it or not. And the patient just noticed the day or 2 after he had the piezo wave treatment, all of a sudden he was having spontaneous erections, which he had not had for years. So he took it upon himself to do a little research and found out which hospitals or institutions had a piezo wave and did some research, found out we had one, got in touch with Ken, and then got in touch with me. So, so he, as I said, had recently had a hip replacement. He had a history of osteoarthritis. He did have a history of diabetes type 2 and of depression, which are pertinent for erectile function from a mood standpoint and from a vascular standpoint. So, I think with erectile dysfunction as a physical therapist, especially when patients come in and they just want to have the shockwave therapy or they've heard we have it, as I mentioned earlier, I can't use only the piezo wave in isolation. We wouldn't be able to, in working for a hospital system, we couldn't bill for it. Right? Nor is that technically probably part of our scope for me to just do that, right? But erectile function is very multifactorial. So it's never just one thing. We have to have the right cardiovascular function. You have to have the right hormone levels. We have to have the right nerve integrity. The pelvic floor muscles have to have enough endurance and enough strength, and they're actually quite important because they have to have enough closure pressure to maintain an erection. Emotional affect, right? What is going on in your life? This particular patient, his wife was very ill, was terminally ill, and he was very depressed over that, understandably. And then, you know, in the erectile function world, prostatectomy is a very big factor. So structurally, do they have their prostate or not? And what kind of difference is that going to make? So there's really, really good literature out there looking at low intensity shockwave therapy for erectile dysfunction. I have a few sources that are in the following slides. It is very clear that low intensity shockwave therapy is helpful for vasculogenic causes of erectile function. So meaning there's a vascular issue, and the thought is that using the low intensity shockwave therapy really helps stimulate cell proliferation, in particular angiogenesis. So is it kind of helping create this new vasculature, right? And to help with that blood flow. So they've done a ton of studies where they look at rat models and different things like that and show it really does stimulate that growth. Sorry. So for this particular patient, you know, he had intact sensation. He had a little bit of pelvic floor weakness, not great endurance. So I did work on that, right? So I gave him pelvic floor exercises to focus on that strength and endurance. We did some biofeedback training so he could really see what was going on with the muscles. And then I used shockwave therapy. So how the protocols are written in the literature for shockwave therapy is pretty exact. So it is once a week for 4 weeks. And you can really do, in terms of the frequency, whatever is comfortable to them. The biggest difference would be, as Ken mentioned, kind of that volume dial, right? For erectile function, it's really low. It's like 0.09, right? And so these patients, they don't feel anything. Whereas when you're using it for more pain diagnoses and for that really mechanical effect, you're going to feel something, right, as the patient. And so this, all you do is hear the little clicking of the device, but they shouldn't feel anything. So Ken mentioned earlier the use of the linear probe, and in this case, it's really helpful, obviously, because of the width that it can cover. And it can penetrate up to 1 centimeter depth and 5 centimeters width, so you don't have to move too much. The shock waves typically are applied in 3 areas, so the corpora cavernosa and each penile crus for the layperson, basically along the shaft of the penis and at the base, so that you're kind of targeting all of that vascular tissue, right, that is needed. Flajecki and his group has done a ton of research on this. There's a really nice systematic review in 2018 where they look at the changes in erectile function scores. And like I said, it's very well shown that it's helpful for vasculogenic causes. Interestingly, they've done a study, a crossover study, where they compared weekly for 4 weeks, right, compared to weekly for 8 weeks. Like the thought is more better, right? And obviously these patients, if they get an initial response, are like, well, let's keep going. Can we make this better? But there's pretty good data to show that 2 courses is not superior to 1. And this even lasted at 12 months. So with this particular patient, at the end of the 4 weeks, he was able to achieve spontaneous erection about 60% of the time. So he wasn't always reliant on taking Viagra or sildenafil for sexual activity. And that's pretty consistent with what the outcomes are for this. So we know it's effective. It's rated anywhere between like 40 to 70% of efficacy. And I think that rings true anecdotally in what I've experienced. So it might work, might be really helpful. It might not, but it's certainly not going to hurt anything. And this just is another nice systematic review that documents kind of all of the research that has been done lately for shockwave therapy in the pelvic world. So looking at Peyronie's disease, erectile dysfunction, and chronic pelvic pain. And what it shows is that for Peyronie's disease, where people might have a plaque or a curvature in the penis, it's like pretty inconsistent, the results. For erectile dysfunction, as I mentioned, clearly helps for vascular sources. When it is because someone recently had a prostatectomy, it's not as conclusive, it's a little more inconclusive. And for chronic pelvic pain, it shows that it's very effective. So those are my tidbits. And then I think we can open it up to questions.
Great, thank you so much both for your presentations. Excellent. So let's get going with some questions. So we have got some pre-submitted questions to start off with. So let's get those up here. And we'll start off with the first question then, Ken. So the question here is the comparison of shockwave therapy to alternative treatments.
Comparative to alternative treatments such as?
So I think the question basically is, what would you probably say the key comparison is of shockwave to alternative treatments that might be out there within treating pelvic health, possibly?
So on the subject of pelvic health, I'll leave that to Mary. I mean,
Okay.
I, as an orthopedic therapist, I tend to deal more with from the kind of the hip down.
So I think in terms of pelvic health, I personally, when I decide, I think this is going to be an appropriate patient who I want to try the PiezoWave with, I think of those patients who typically, obviously it's going to be more deeper, right? And I go to the PiezoWave because not from an erectile dysfunction, but from a pain standpoint of, I do think there's something going on with like the coccygeus, the puborectalis, some deeper muscle. And especially for patients who are not comfortable with internal treatment, this is a really nice way to get tissue depth and kind of that mechanical release without being as invasive. I also really like it, as I mentioned, when I think there's something more fascial going on and there's more fascial restrictions or that nerve sheath or something like that. So I almost think about it as, I really do think about it from that mechanical compression standpoint. Or I think about it from a dry needling standpoint. So I personally am not licensed to dry needle, but this is what I use in lieu of that if I think there's kind of a persistent trigger point that I want to try and break up.
Okay, perfect. Great, thank you for that.
In terms of alternatives to other treatments in the orthopedic non-pelvic population, I mean, there are some studies looking at the use of shockwave in treatment of tennis elbow and Achilles tendinopathy. Most of those are showing significant improvements, 30 to 60% greater effectiveness in those treatments as compared to just a traditional manual therapy or exercise-based approach. For me personally, my experience has been that if it is a disorder that's involving the sort of the tenoperiosteal junction, so tendinous treatments where it's difficult to get into that tissue just because of the density of the fibers and whatnot. Again, I've got a patient right now who had been suffering with Achilles tendinopathy. He's a restaurateur on his feet, 12 to 15 hours a night, has been in pain for the past year. He's now been under my care for just over a month, and his pain is about 20 to 30% of what it was when he started, and the frequency has dropped significantly. Now, just like anything else, when you look at multimodal studies, the more things that we bring in, the greater the chance of our success. So there's very rarely is there ever a time when like somebody's just coming in, shock waving them and sending them out the door. So, as we shared earlier, Mary and I both use extensively. We use, the TechR therapy from Winback is a great preparatory tool because that is a very deep heat that prepares the tissue well and conditions the patient for, what can sometimes be a somewhat unpleasant treatment. Shockwave, for anybody who has felt it, my introduction to shockwave was with a radial device. And then as I started to look at, that was for my own treatment of my knee. But then as we started to look at this for what we were going to buy and put in our clinics, we started looking at these alternatives. And the minute that I felt the shockwave, the piezo wave, it was such a markedly different sensation I knew it had to be different because it was much more focused, right? And much better tolerated. So yeah, that's, I guess, a very long answer to a simple question.
Great, thank you so much, Ken. All right, so the next question we have here, so it's please present evidence for the use of shockwave therapy on pelvic complaints, which Mary, you've covered quite a lot already. So I guess, is there anything else to add on that, or is the research still growing in this area, would you say? Would you say there's anything lacking in research?
I mean, I think it's growing. I think it's definitely lacking in some. I think the area to watch for erectile function will be looking at other sources of erectile function, so not just vasculogenic. And I think for the pain diagnoses, I think some more stringent randomized control studies need to be done. At the same time, as Ken just mentioned, are you really going to treat just that, right? You're probably going to be doing some other things. So, but I think it is emerging, and I think it will continue to grow.
Yeah. Okay, great. And again, staying on the evidence-based type of question, it says, do you have any evidence of effective use of the focus shockwave in the pre-prostatectomy patient? So
yeah, so I think this is what I kind of touched on. That systematic review of Fajecki does a good job explaining that it might help, but there's not really any clear data that it's going to help prostatectomy. And the theory is that, you know, after having your prostate removed, it depends on, did you have radiation therapy? Was there hormone therapy? What approach did they use? You know, they might say these procedures are nerve sparing, but they still have to move nerves out of the way to get your prostate. And so, you know, there's a lot of factors that go into treating prostate cancer that I think it's hard for them to say exactly why the erectile dysfunction occurs, because there's a lot of factors of why it could happen.
Okay, great, perfect. Thank you for that. And then Mary, this question, how does shockwave therapy fit into a biopsychosocial approach to treatment within this population?
I'm going to let Ken answer that.
Yeah, that's a good one. I love these kind of questions because I think that it touches to some degree on, there's a lot of controversy right now. I mean, obviously people are writing about why aren't we, everyone likes to talk about evidence-based practice, but a lot of those people that talk about it don't always do it. And, you know, those of us that I think are more thought leaders in terms of how we practice, pioneers, innovators, you know, you're taking sound physiologic evidence and you're applying it into practice, and you're looking for clinical results, right? So there is evidence out there that does support this as a modality. And what I like about the approach to the you know, the psychosocial aspects of pain, particularly with modalities, is that when we're there, you know, to Mary's point, there's some of these things where we think it's helpful, and there's others where we know it's helpful, but we're not harming them, right? So I have 10 to 15 minutes of time where I'm doing my treatment and I'm able to talk and converse with the patient. I'm educating them on what I'm doing. I'm listening to their response to pain. And invariably, what people will say, because it's like that, the old adage, when you take your car to the mechanic in the garage to get it fixed, it's like, it's not making that sound. Or in the case of patients coming to us, yeah, I know it hurts, but it's not, I can't make it hurt today. The one thing that's really effective, particularly about the piezo wave, is how, if it is a trigger point or if it is a soft tissue related pain, how helpful in the diagnostic and pinpointing and targeting where patients' pain perceptions really are. And we know the types of pain responses we would expect. I know if I hit the target tissue correctly, I'm going to get that, oh, that's like a toothache. Mm-hmm. If I get a feedback that's like, that's kind of a sharper pain, or like that travels, or it's kind of burning, then I know I'm hitting a nerve, or I'm probably getting something, you know, that maybe I wasn't targeting. So we learn those types of patient responses to treatment, but invariably patients will say, yeah, that's the spot, that you found it. You found it. And that, I think, is an important part of establishing the trust that the patient then has in us as a provider. And that's why Mary and I see people that come for hours away for care, because they've gone to all these other places where they're just getting exercise or something, and that's not it.
And to Ken's point, just to add on to that, you can really, like, diagnostically, you can almost hear a difference in the pulse, and the patient will tell you that's it. And with repetitive treatments, that response will get less and less. It will take less of the volume, so to speak, of that intensity to get the same response. I mean, pardon me, more volume to get the same response. Yeah. So you can also see that objectively, and the patient can see that, which again is very rewarding on all ends.
Yeah. So that the volume scale that we talk about, it's like the intensity. It's on a scale of 0 to 20. Most people will have some sort of reaction around a 5 or a 10. So between 25 and 50% of the total power. Invariably, what we'll see is, because again, with mechanotherapy, we are using mechanical stress to create a chemical response where the body is increasing or improving the resilience of that tissue and its tolerance to stress. So in a sense, we're kind of like training the tissue strength or the tissue tolerance to stress by using this targeted, focused shockwave. And once I've maxed somebody out, that's why this is not something that we do indiscriminately for eternity. Like, once I've got them up to a high level of tissue tolerance, they don't need it anymore, and we move on to the exercise-based or movement-based program. But because we've corrected their pain early on, we've managed it, there's a much higher degree of trust, I believe, in their adherence to what we're telling them to do from here on.
Great, thank you so much, both. So just as I'm finishing off these pre-submitted questions, if you do have any questions that you want to ask through the live chat or the Q&A, please just pop those in there and we can address them as well. So Ken, maybe you could help with this question. Any tips about determining the depth of treatment?
So determining the depth of treatment is a great question. I think there's, some of it is sort of kind of a best guess or of the anatomy, but to have more precision, we will use the musculoskeletal ultrasound. And by using the MSK ultrasound, we can then actually visualize and calculate the depth of the target tissue. So if there's something very specific that I'm trying to hit or target, I'll use it that way. Experience that's where we started, but experience is kind of given me pretty good guidance in selecting the appropriate depth in gel. Like, I know I'm going to use a number 10 with, with patellofemoral pain. I'm going to use a 20 or a 30 if I'm trying to get a deep hip. So there's some of that. I mean, you can be as precise with it as you want, but MSK ultrasound is very helpful in determining the accuracy of that depth.
Great, thank you so much. So the next question, what is the percentage of successful treatments for ED with focused shockwave? So Mary, I think you, 60 to 70%, did you say?
Yeah, in terms of the efficacy, and then in terms of like the quantity, right? Really, 4 visits, you should be fine.
Okay, all right. And that 4 visits compared to
8.
Compared to 8.
Compared to like a double dose.
Yeah.
Right? Just as effective.
Yeah, perfect. Okay, and the next one, can you treat pubic symphysis disorder? Again, I think you briefly mentioned it. I think this is a good sign that your presentations were very informative. We're answering all the questions already. But is there anything to add on to that? I think
for the pubic symphysis in particular, so I use this a lot for SI joint dysfunction and like along those ligaments posteriorly. But I would say the pubic symphysis is a much more sensitive joint. So I would definitely use the shockwave along the proximal adductors. at that tendinous junction where they attach, because they often just have too much tension contributing to the pubic symphysis, but I probably wouldn't do it right over the joint.
Yeah. Okay, great.
For comfort.
Perfect.
I think along those lines too, in some of the, on the posterior side, I will deal with high hamstring strains and tears. And, you know, again, for those of you from a manual standpoint, you know, I'm not a pelvic therapist like Mary, and I don't accidentally want to be one. So for me, having that therapy source, you know, it gives me a little bit greater sense of, you know, just personal comfort in how I'm manually handling or dealing with my patients. So I kind of like having a device between me and them in that area.
Thank you. Yeah. And the last pre-submitted question we have here is, so what shockwave would you advise for healthy, active women and menopausal women with pelvic girdle pain?
Sorry, can you say that first part?
So it says, looking at pelvic health, what shockwave, I guess, of application would you advise for healthy, active women and menopausal women with pelvic girdle pain?
So honestly, I mean, any musculoskeletal like overactivity or trigger point, you know, I would feel comfortable using it on the adductors, the hamstrings, the piriformis, the glutes. You know, obviously you are not applying this internally, or I should, you know, maybe it's not obvious, but I do not insert this. And so I do think, you know, like anyone who has pelvic girdle dysfunction, it would be safe and effective.
Great, thank you so much, Mary. Thank you. So I just got a few more questions here. I don't think anyone's put anything through at the moment. No, so not a lot of questions coming through. Oh, there is a few questions, sorry, I've just been noted, but we will address those in a minute. Just a few questions that I have here is, what would you say the contraindications of shockwave are specific to pelvic health diagnosis? So for pelvic girdle pain, or is there any for pubic symphysis?
In terms of like, you know, I would not use this on a pregnant patient, would be probably my largest contraindication in terms of pelvic health.
Okay.
But afterwards, I don't really think there are large contraindications. Again, I mean, because of the effect of like cell proliferation and things like that, if a patient had active cancer or had recently completed treatments, that would be the other thing I would consider as well.
Okay. Perfect, thank you. So I will address the questions which have been submitted then. So we have the first question: if you wanted to get trained in how to use this machine practically, then how would you do this?
So, I mean, it's a fairly easy question to answer. I mean, I think that's one of the things where, you know, having a network of providers that you can reach out to, the actual operation of the device is actually remarkably easy.
Yeah.
It really is very simple. And I think for all of the technology that we are proud of in our clinics, this is probably, I mean, it has an on-off switch. It has a frequency button and an intensity button. And that's really all that's needed. If you know your anatomy and you know your target tissue, it's pretty elementary from there. I think where, you know, getting some input or feedback from a clinical, you know, specialist can give you some technique or maybe positioning is probably the more significant how-to. And I know that PiezoWave, I mean, we've worked on and helped to contribute to a training manual that is there that goes through a lot of your main positioning questions and applications. So that's pretty straightforward, but I also know that the f-ESWT team there in the UK is outstanding, and they do a fantastic job of teaching and training.
Thanks, Ken. Yeah, so like I say, I think, like I said there, Elevation, their e-learning hub is an amazing resource, obviously, to back up the training for this sort of machine. Then, like I say, it's your local clinical app specialist who's going to be able to help with that ongoing support. Is definitely the way to be competent, I think. with that system. And we have a question from Jo Gibson. She says, does radial shockwave also work in this cohort, just less effectively?
I can address a bit of this, and I'll let Mary address the actual clinical piece. So before we put something in the clinic, or we use it, I'm going to try it. I will tell you, I would not put a radial shockwave on any part of my body again, especially very sensitive ones. But I can say that I have used the, let me clarify for the group, I have used the linear device mainly just because I wanted to see what it felt like. And I wanted to make sure that if I did have a patient that I referred in for treatment, that I could honestly, tell them like, no, it really is pain. It doesn't hurt. Because if you've been treated in a joint or in a tenoperiosteal junction or some other soft tissue application, it can be a very exquisite type of sort of painful sensation. And, there is none of that with particularly the ED applications or applications on the penis. But in terms of its clinical effectiveness, I'll let Mary address that.
In terms of the radial, I don't have any experience with it because I've only used the shockwave here and have our device. So I can't really speak to it, I'm sorry. But I agree with Ken, I probably wouldn't go there if it was something that was very painful.
Yeah.
I mean, imagine taking a hammer and just tapping away. It just doesn't sound pleasant to me at all.
No,
that's essentially what you're doing with radial.
Okay, and then I guess with the focus shockwave then, so is there an element of, the treatment application causing some sort of pain? Is that normal to experience? Yes. Would you communicate obviously that fully with the patient? And, how would they expect some after treatment, for example? That's normal for shockwave.
After treatment, usually they feel better. I mean, I do expect that ahead of time. Yes, you're probably going to feel something that's going to feel uncomfortable. I'll describe the toothache type sensation. But it's kind of a good hurt.
Yeah.
Like, they're in the right spot. And I've had it done on myself, so I know what it feels like, right? So I can articulate that. And then usually they feel better after, and they have more lasting effects.
Okay, great, perfect. All right, so I think we've cleared all the questions in there. Just getting a heads up, I think we have, perfect. So that's come to the end of the questions. So thank you so much, Mary and Ken, for both presentations and answering the questions there. And thank you everyone for joining us as well this evening. I hope you've enjoyed it. So following this session, you will receive a survey along with the link to the webinar recording, so you can go back and review those slides at any point. We would really appreciate any feedback or suggestions for future webinars. And you can also register to our Physical Academy. So I think if we go along with the next slide, you can register to our academy, which we have all our past and previous webinars and other educational resources on there that you can review as well. So as well, if you have any other further questions or want to find out more about any of our products or further educational events, then again, just contact us at info@physiquip.com. So otherwise, thank you and have a good rest of the evening. And guys over in the United States, have a good rest of the day.
Thank you. Thanks for having us.
Bye.